Hello, this is Janet Michael. In addition to hosting The Valley Today each weekday at noon on the River 95.3, I also produce podcasts, and I'm excited to introduce you to a new podcast series in partnership with Lord Fairfax Community College. Having provided higher education and career training for the past half-century, LFCC is tightly interwoven into the fabric of the Northern Shenandoah Valley and Piedmont regions. Join me every week for conversations with current and former students to hear their funny and inspiring stories as we learn about their journey to higher education, the role that LFCC has played, where they are now, and where they plan to go. We'll also talk to current and former professors about their experiences and best memories of LFCC over the past 50 years. Get every single episode as they're released on our website at theriver953.com under the podcast tab, or you can subscribe for free in Apple Podcast, Google Podcast, on Spotify, Amazon Music, wherever you listen to podcasts. Just search for LFCC Stories. Hello and welcome to The Valley Today. I am your host, Janet Michael. Happy Thursday as you are listening to the show today. It is American Heart Month and it is our Community Health Partnership Day with Valley Health. That means I am on the Zoom screen chatting today with Dr. Edward Kofsky. He is a cardiothoracic surgeon with Valley Health Cardiothoracic Surgeons. Sure. He is also the surgical director for the Coronary Heart Disease Clinical Council and the Valvular Heart Disease Clinical Council. And Dr. Kofsky, I wasn't really going to, in the beginning, rattle all of that stuff off, but in our pre-show conversation, you were explaining to me a little bit about these councils and how doctors come together now in the heart department to be able to specialize to give a patient the best kind of care that they need. Let's start, though, with heart disease, because I've been doing a little bit of reading, and heart disease isn't as generic as I think a lot of us use the term. What exactly is heart disease?
Heart disease is really a complex series of problems that exist where patients can have one or many versions of heart disease. But the classic understanding of heart disease, I think you're right. People feel that it's sort of this big box of problems that are unique to our area of care, where patients have long-standing problems related to other medical conditions that can cause their hearts to ultimately develop problems that can lead to things like heart failure. And ultimately, these are very high mortality medical problems. But heart disease is really a series of separate issues related to various aspects and elements of the heart itself. And in very broad terms, there are conditions related to the coronary arteries, which supply the heart muscle with blood. There are conditions related to the valves within the heart, which prevent the blood from backing up into the wrong places within the heart or from backing up into the lungs. And there are conditions related to the actual muscle of the heart itself, where the heart muscle may not function normally or may be diseased by any number of different kinds of processes, including infections and connective tissue disorders and the like. And then there are also problems related to the electrical conduction systems of the heart, the parts of the heart that provide the pacing to the heart and to the transformation of the electrical signals that cause the heart muscle to have its own unique beating, which causes the heart muscle to work as a sort of a synchronized pump. So in general, those are the major cardiac conditions that can exist. There are some others that are much less common, some of them being related to some tumors or growths or neoplasms that you could have on the heart. And then there are other secondary cardiac conditions that can be caused by other systemic illnesses. And these are common chronic illnesses called diabetes mellitus and hypertension. So hypertensive heart disease is probably the most common of all the cardiac conditions. It's a multifactorial process that occurs usually in adult life. There are a number of predisposing conditions to hypertension. Probably the most common is a genetic predisposition, but there are other things that most folks know can impact the high blood pressure, and those things include tobacco abuse, alcohol abuse, stress and stress-related conditions, And hypertension or elevated blood pressure can have a negative impact on the heart in many ways, both on the heart muscle itself and on the coronary arteries that supply the heart muscle with blood. And hypertensive heart disease is probably the one condition that gets the most public relations information out there to folks because it's the most common. And of course, hypertensive heart disease also predisposes patients to other conditions such as stroke, which is not directly related to heart disease, but certainly can be tied to heart disease because of its close relationship to hypertension. But in general, heart disease is not one manifestation, but it is usually some aspect of those 4 or 5 areas that I've mentioned. Coronary artery disease, or blockages within the coronary arteries, is one very significant area of heart disease where we have various kinds of options to treat patients. And myself as a surgeon, we have certain tools in our toolkit. My cardiology colleagues have other tools in their toolkit, both medical tools and interventional tools to treat these problems. For valvular heart disease, the most common treatment options or medical management options to try to reduce whatever the valve problem impact is on the heart. Some valvular heart disease problems don't have any medical solutions. A good example would be aortic stenosis, which is a common problem out there in the community, which really only has one treatment, replacement of the valve with a new valve. We've been fortunate in the last 10 to 15 years to have really an evolution in the way that we treat aortic stenosis, and it has become much more of a treatment option for patients who previously weren't candidates for treatment for aortic stenosis because of advanced age or multiple comorbid conditions. The treatment option has changed from just a surgical option through a large incision in the chest to some more minimally invasive options involving smaller incisions, and now most recently options that don't involve any surgery at all, but are now purely catheter-based treatment options for aortic stenosis. The conduction system diseases of the heart are often treated by subspecialists of cardiology called electrophysiologists. And the most common kinds of problems that electrophysiologists treat are arrhythmia disorders of the heart, the most common of which is atrial fibrillation. Atrial fibrillation is a common problem in many millions of Americans. Probably 4 million Americans or more are treated for atrial fibrillation, and many more are not diagnosed. This is a problem that has significant consequences because the irregular heart rhythm can lead to reduced heart muscle function and inefficiency of the heart muscle as a pump, and can also predispose patients to blood clot formation inside the heart, which can unfortunately lead to a condition that can predispose to stroke. So the idea of trying to control these arrhythmias has been around for 20 to 30 years with medications, with electrical techniques to try to ablate or remove these pathways of arrhythmia, and the electrophysiologists have expertise in those areas. With regard to other areas of heart disease, the medical cardiologists are really the experts that manage all of these disease processes as the primary touch point. Once a patient is recognized to have any of these conditions, they're generally referred to a heart specialist or cardiologist.
Let's take a quick break, and I want to talk about some of those treatment options. In the pre-show conversation that you and I were having, you were explaining that it's no longer one size fits all, and now there is a team of people that help treat someone who comes in with any one of the things that you were just explaining. Can we talk about some of those treatment options in the next segment?
Of course.
Okay, we're going to take a quick break. When we come back, we're going to continue our conversation with Dr. Edward Kofsky. He is a cardiothoracic surgeon with Valley Health Cardiothoracic Surgeons. It is American Heart Month, and this is part of our community health partnership with Valley Health. And we're going to continue our conversation with Dr. Kofsky in just a couple of minutes.
Got a financial decision to make or a goal to reach, but you don't know where to start? You've come to the right place. Introducing Quick Money Chats with the Northern Shenandoah Valley Financial Education Program. Visit tinyurl.com/quickmoneychat to schedule a virtual chat with a staff member or trained volunteer. We won't tell you what to do, but we will give you the tools you need to choose wisely. And because Virginia Cooperative Extension is part of Virginia Tech and Virginia State, your land-grant universities, you can be sure that our information is credible and trustworthy. And you'll know that we aren't trying to sell you something. Maybe you want to improve your credit score, or reduce your banking overdraft fees, or even figure out if you can afford to buy that car. Sorting through tons of information on the internet can be overwhelming, and sometimes it can be hard to know who to trust. Schedule a quick money chat and get the information you need to take action. Go to tinyurl.com/quickmoneychat and get financial education personalized for you.
Welcome back to the Valley today. I am your host, Janet Michael. Happy Thursday as you are listening to the show today. It is Thursday of American Heart Month. So I am on the Zoom screen today with Dr. Edward Kofsky. He is a cardiothoracic surgeon with Valley Health. This, of course, is part of our community health partnership. And we talked in the first segment, Dr. Kofsky, about all the different heart diseases. And then during the break, you were telling me that there is still one more that's fairly common. Give me a rundown of what that is, and then let's talk about some treatment options.
The one area that actually is probably the most devastating area of heart disease and the most lethal is really under the general heading of heart failure or congestive heart failure. Heart failure really is the end-stage manifestation of all the things that we mentioned earlier: coronary artery disease, valvular heart disease, electrical problems with the heart. When all of these problems manifest in some heart muscle function degradation, as I mentioned earlier, with the muscle itself being one of the components of heart disease that really can make a significant negative impact on someone's quality of life. When the coronary disease has led to heart attacks and reduced heart muscle function, and may also impact the electrical conduction system of the heart so that the heart does not beat as efficiently. And then the valves may also begin to fail and leak because the heart is becoming dilated. Patients develop various forms and severity of either left-sided or right-sided or what we call biventricular heart failure. And these conditions are usually mostly managed medically by a combination of medicines and some electrical devices that can help improve the efficiency of the heart. But in the end, these diseases can progress. Heart failure is probably the single most lethal of all the medical problems, certainly the one most common cause of hospital readmissions in hospitals across the country. And there are the exciting treatment options in heart failure include mechanical support that could be either short-term or long-term, ventricular assist devices, which we don't implant yet at Valley Health, but which is part of our intermediate term plan. And then, of course, heart transplantation for patients who have met criteria for transplantation can be a long-term and very successful option for them. So that's sort of the final sequence in progressive heart disease.
And then we were talking pre-show about all of the different options that are now available, not just from a surgical perspective, but just treatment overall. That I joked with you earlier and said, you know, it's not your grandfather's bypass surgery anymore, open heart surgery anymore. And you said it's not even your grandfather's heart disease anymore. It's a totally different approach, even in just the last 10 or 15 years, how you would treat a patient that comes to you with any number of heart issues.
Yes, that's right. And I think what's fair to say is that there's been enormous progress in research around primary and secondary prevention for heart disease. We have made discoveries in ways that we can reduce the severity of heart disease, how we can impact patients who have particular risk factors. Just the advent of cholesterol therapy, the use of statins, and the aggressive use of high-dose statins in particular in the last 5 to 10 years has been shown to be associated with reduced overall mortality in patients who have, for example, coronary artery disease. And we're seeing actually fewer patients presenting with severe disease that has needed intervention. So the volumes of patients that have required interventions with severe coronary artery disease has reduced in general, and also the numbers of patients that are being referred for coronary bypass surgery has also reduced significantly over the last 5 to 10 years. And a lot of that has to do with behavior modifications that patients have been educated on in terms of diet, in terms of exercise, in terms of other lifestyle choices and reducing cigarette and other tobacco use. All of these things have really impacted our need to use aggressive treatments for patients. So in that way, it's not your father's or grandfather's heart disease. It's because we've made a lot of progress in improving some of the somewhat dreary statistics related to the high impact of heart disease on mortality and certainly quality of life. Don't get me wrong, we're still left with a lot of very advanced heart disease, but we've also improved the way that we approach advanced heart disease. What has become really a paradigm shift in the treatment of cardiovascular diseases is this idea of a heart team approach to treatment of various disease processes. So rather than being surgeons or cardiologists separately addressing problems within cardiology or cardiac surgery, we're now becoming disease specialists. We may treat several diseases as an individual, but we focus our attention and our collaboration by a disease focus, so that if a patient has advanced coronary artery disease, for example, we'll address that patient's coronary disease very frequently with our cardiology colleagues and try to find the best treatment strategy for that patient as an entire patient rather than just as what the anatomy of his disease is, so that we're doing a better job addressing the needs of that patient, really focusing and refining our strategy for each individual and using collaborative tools and a much more sort of multidisciplinary approach to how we take care of problems. And this paradigm shift really started in our treatment of valvular heart disease, in particular aortic stenosis. As I referenced earlier, this new treatment of aortic stenosis with a transcatheter approach really is the perfect example of the amalgamation of expertise of surgeons and cardiologists and imaging experts, echo experts, and other medical specialists who are involved in the overall care of some of these patients who are very, very elderly with other comorbidities. So these models of care have really caught on and really, I think, raised the level of care that we're providing for our patients to a very measurable degree.
And I think a lot of people don't realize the impact that it could have on them going through these different procedures. Back in the day, when you said open heart surgery, that was you're cracking open their chest and all kinds of things are going on. The phrase minimally invasive now is an everyday phrase within Valley Health. Some of these procedures that you do on an outpatient basis. People aren't even spending a night in the hospital.
That's true for some of the interventional techniques that we're using to treat some various elements of heart disease. We're not quite doing outpatient cardiac surgery yet, but we are making substantial inroads on how we are able to do open heart surgical procedures to patients where we're getting them out of the hospital in 3 days, not infrequently. Rarely we'll get patients out in 2 days, where it used to be routinely a week to 10 days in the hospital. So we're really looking to apply a variety of principles that are really based on the patient experience and in heightening the patient experience by addressing issues that the patients and families previously had not been aware of. Just expectation management, teaching about what to expect in terms of the amount of pain they may experience, about the length of stay in the ICU, and about what it means to participate in their own care in terms of their pulmonary toilet and other things, really has made an impact in our ability to get folks feeling like they're part of the treatment plan. And I think that's made a big difference for us. In terms of less invasive approaches, we're constantly evolving as a specialty. I think the general surgeons have been more successful at deploying robotics and other very minimally invasive tools to the vast majority of their practitioners, whereas in cardiac surgery, robotic solutions are evolving slowly. Less invasive procedures are evolving more quickly using incisions, but smaller incisions. And there are smaller incision options for all sorts of cardiac surgery these days, including valvular heart disease, and coronary artery bypass surgery. One of the areas that we're looking to highlight is the minimally invasive coronary artery bypass surgery. And what is minimally invasive bypass surgery? Well, it can be defined in many different ways, but usually when we talk about minimally invasive procedures, we're talking about small incisions done using special enabling tools and instruments that give the surgeon the visualization that he needs to do a good operation, yet through a smaller incision and one that would provide less pain, less trauma, less risk of infection, less damage to tissues that may damage nerves that might lead to longer lasting discomfort, and also to maintain the outcome of the operation at the same high level that we were able to achieve through larger incisions. For bypass surgery, traditionally, we would be taking care of the patient through a large incision that would involve splitting the sternal bone and putting the patient on the heart-lung machine, stopping the heart, and operating on the heart while it was still, with the circulation and ventilatory needs of the patient being handled by a machine. Over the years, surgery has evolved so that some patients are now having surgery where they may still have an open sternal incision, but we don't use the heart-lung machine. And instead of having a still heart, we actually operate on the beating heart using special tools that are able to isolate those areas of the heart that we're working on so that they are still. And then we have other tools and tricks to sew vessels onto a beating heart while it's still doing the work and providing the circulation to the patient. There was a time when surgeons had the pendulum always swings in technology from one end to the other. And at one point, maybe 10, 15 years ago, many surgeons were doing half of their cases using off-pump techniques. And then the pendulum sort of swung back when maybe the outcomes were not as good in certain hands as in others. But now the pendulum's sort of swinging back, and those surgeons that are really adept and talented to do these off-pump beating heart procedures are now applying those same techniques through small incisions rather than going through the sternal bone, small incisions on either side of the chest wall around the level of the nipple, maybe a 4-inch incision, which gives enough room for the surgeon to see inside the chest. We use different anesthetic techniques so that we're able to use only a single lung for ventilation, so that we are able to rest one lung. So it gives us visualization of the chest cavity. We could harvest an artery off the chest wall called the internal mammary artery, which is a very good new source of blood flow to the coronary vessels beyond blockages. And we're actually able to use that artery and open the sac around the heart and sew that vessel onto the important blocked vessels beyond where the blockage is, using what we call beating heart techniques. And in a nutshell, that's what minimally invasive bypass surgery is. Some surgeons actually are able to do multiple bypasses through the same small incision and use the artery plus some additional conduits, either an artery from the arm called the radial artery that we harvest that's safely, or using veins from the leg called the greater saphenous vein, which are harvested from the leg minimally invasively. So these minimally invasive approaches really give us a variety of alternatives. These minimally invasive options are not available for everyone. They are available for certain patients who have specific kinds of blockages in certain locations. The question is, what benefit do these bypasses provide? Well, there are stents that can be used by our interventional cardiologists to open up blockages from within the vessel without the need for any kind of operation, but just a puncture in the groin. Those are good solutions, but we do know the evidence over many, many years has shown that the best new form of blood flow to the vessel that runs down the front of the heart, which is called the anterior descending vessel, is an internal mammary artery graft to that vessel called the left anterior descending. So an internal mammary graft really provides the best new form of blood flow, the best restoration of blood flow to the heart for coronary disease, and it now can be done through a small incision. The issues of how we as cardiologists and cardiac surgeons decide which patients are best suited for this procedure is in evolution right now. So we're sort of developing and still deciding the best patients to be referred for this. But patients can be educated and understand what these procedures are and do a little research on them themselves. And they could ask their physicians if they're candidates for this approach to coronary artery bypass surgery.
I think that's one of the things too that has changed over the years is most patients have become advocates for themselves in their healthcare, which has got to make your job a little bit easier too if they understand what it is that is about to happen or what their options are so that they can do a little research and have that conversation with you.
What you're saying is true, and then I'll take it another step further. In our efforts to really improve the patient experience, which I think is one of the sort of the hallmarks of, I would say, the next 3 to 5 years of focus, particularly in cardiac surgery, particularly at Valley Health, we want the patient experience to be a positive experience. Nobody really wants to come to enjoy their bypass surgery, but we want it to be at least a positive experience where they felt like the providers of care were cared about them. They wanted them to be part of the discussion, part of the solution to any problems that might come along. And what we're learning is that this concept of patient engagement is so important and makes patients feel so motivated and so interested in their own health that they're more likely to do a better job in terms of the recovery process and the rehabilitation that's necessary to get them to where they need to be. And so we've engaged in some of the tools that are available for us to engage with our patients, not just before surgery and the education and preparation for surgery, but also during the hospitalization and after discharge, so that the patient and the care team can maintain in close contact throughout the continuum of care, so that there's a ongoing conversation about pain management, about exercise and ambulation, about expectations, about do's and don'ts, about what's allowed and what's not allowed. And so all of these things are great. The fact that patients want to learn more about what their medical treatment options are is fantastic, because the more informed patients are, the more educated they are, the job becomes easier for us to convince patients that they need therapy, there may be options, that their options are the following. And we think that engaging the patients and families and helping us make decisions, particularly in tough situations, is always a healthier and better decision-making tool than for us making the decisions for them. It's just, I think, a much more user-friendly approach to the delivery of care.
Well, Dr. Kofsky, thank you for taking some time today and having this conversation. It's been fascinating. I've learned all kinds of stuff. I'm going to start going off in my regular conversations and spouting about heart health and heart disease now. So if you get some patient that comes in and says, well, Janet said, re-educate them, because I'm sure I probably got something wrong.
It's our pleasure. We're always willing and interested in speaking to patients if they want to call us and have any questions about any aspect of heart health. We're always delighted to speak to folks out in the community and to try to lend a little bit more understanding to what is a very complex series of problems.
Well, we are going to wrap up our conversation today with Dr. Edward Kofsky. He is a cardiothoracic surgeon with Valley Health. This has been part of our community health series in partnership with Valley Health. Remember, February is American Heart Month, and I did a little other research and found a cool little infographic, 28 Days to a Healthy Heart. You can find that image on the show notes page. Just go to theriver953.com and click on the podcast tab. I'll be back tomorrow. I've got a brand new episode in store for you. We're chatting with some master gardeners about their Gardening in the Valley symposium that is going virtual this year. So meet me back here tomorrow, just a few minutes after noon.